Top Med Talk.
Alrighty, well, this is Top Med Talk at Anesthesiology 2018 here in San Francisco for the annual meeting of the American Society for Anesthesiologists. I am Desiree Chappell, host of Top Med Talk, and I have here my co-host, the Monty Mythen, editor-in-chief.
You must be getting tired now, Desiree. I've progressed from being, I've just remembered Monty's here, to the Monty Mythen. You've just had something to eat, haven't you?
I did. I had
a coffee as well?
I had a coffee and something to eat. I'm feeling much better. Thank you.
It's great to be here in allegedly sunny San Francisco.
Yeah, right.
But we haven't actually been outside
No,
today.
we haven't.
At all.
No, not at all. But here we are in the Connection Center.
We are.
Which is traditionally called the Exhibit Hall, I think, the exhibition. So in the Connection Center, we are lucky to be here on Smith's Medical Booth 1519, 1519. And we're able to broadcast to everyone here at the meeting as well as those who are listening to us at home.
Around the world.
Cool thing. Around the world, yes. How many countries are we in, Monty?
90 countries around the world, and I was just checking it includes South Africa, for example.
South Africa, which brings us to our guest, our very special guest that we have here this afternoon on Top Med Talk. We have Dr. Brendan Carvalho. He is a professor at Stanford. He is the chief of obstetrics anesthesia there, and he's also been the immediate past president of SOAP. Brendan, thank you so much for joining us. We really appreciate you taking the time out of, I know, this very busy meeting for you.
It's a great pleasure.
Yeah, to sit down with us. So what is SOAP, Brendan?
Well, most people think it's something to clean yourself with. It's the Society of Obstetric Anesthesia and Perinatology. It's the premier obstetric anesthesia organization in the United States. And I'd say the world, but I have Monty here, and he's going to say that OAA is. But
No. And you're originally from?
I'm originally from South Africa.
Yeah.
I did my medical training there.
Okay.
And then I came to the United Kingdom, where I spent way longer than I should have.
We'll talk about that later.
I did my anesthesia training there.
Okay.
And then I've been in the United States for almost 17 years at Stanford.
Okay. At Stanford, you've been there the whole time. Okay. Great. Well, today and throughout the weekend, our theme for Top Med Talk has been all about enhanced recovery and really optimizing and improving the care of the perioperative surgical patient. And you know, one of the things that we talk a lot about here on Top Med Talk and have had guests talk about is enhanced recovery for C-section, elective C-section, and for the obstetric patient. And so I think it would be great if we could talk about that today. Monty, did you have a question? We were talking about this earlier.
Yeah, so I'm a little bit confused about enhanced recovery when it comes to obstetrics and Caesarian sections, because I mean, myself and my darling wife had a few babies, so I've had some upfront and personal experience, including one of those born in America. I spent a lot of years as a trainee back in the days in the United Kingdom on the labour ward. It's not my subspecialist area, but I spent a lot of years on the labour ward, and it looked even way back then that whatever the principles of enhanced recovery are, it was all sort of happening already. I mean, tubes were being pulled out and people were being allowed to eat and drink straight away. So what's all the fuss about?
Well, it's interesting. In a way, Caesarian delivery should be the poster child of enhanced recovery, because we've been probably doing it for 2-3 decades, but I don't think we put a name to it in many ways, and we probably didn't adopt all the principles that we probably should have. It is a surgical model. It's abdominal surgery, similar to hysterectomy. So there's no reason why it shouldn't be one of the many surgical models that enhanced recovery is applied to. And we're very late to the party. Of all the surgical models, for whatever reason, Caesarian has been left behind as, you know, one of the official enhanced recovery programs.
Because we've been lucky enough to do some sessions with evidence-based perioperative medicine meetings recently, and we've been hearing data presented from American programs with Caesarian section. And people seem to be hanging around in hospital for 3-4 days. What are they doing?
Most likely getting their baby breastfed and meeting the metrics of discharge. America's very different to, for example, the UK. We have laws governing how quickly a woman can get thrown out of hospital. These start in 1996. They passed an act to forbid hospitals pushing women out before they were ready, and they said 3 days for a vaginal delivery and 5 days for a Caesarian delivery. This shouldn't be interpreted that you should stay for the 5 days,
Yes.
but it's taken a little bit of the essence out of rushing someone out of a hospital situation. And in a way, we haven't really adopted the principles of getting women at least ready to leave, even if they choose to stay longer.
Because there are, certainly the surveys we were presented suggested that there are a substantial number of women who would like to get home as quickly as possible.
Yes.
And there's no clear clinical, for the mum now for a second, there's no clear clinical contraindication to that.
Absolutely.
But we recognise that some of those extra steps, like establishing breastfeeding and checking everything's fine with the baby, etc., may need to be processed slightly differently.
Yes. And there's a big difference between first-time moms and experienced moms, where you know the deal, you just want to get out of there, you want to get home as a second or third-time mom, whereas if it's your first experience, you're a deer in headlights and you actually need to stay longer often to get the knowledge to help you look after your child.
So to us boys who've only observed it should probably be quiet for a second and let mum talk.
No, there are so many questions and so many, different ideas and roads that we could go down. And just from my own personal experience, knowing the similar situation, first kid, is pretty tough, and lack of support at home. We were talking about a little bit earlier. You're not ready to go home sometimes because you just don't really know what to do exactly. One of the things that I find interesting that we were talking about before we got started here was the fact that you kind of, in obstetrics, though, feel like you've been doing some components of enhanced recovery, specifically around pain management and things like that. And I know it's a huge issue for mothers, especially C-sections, usually if the first is emergent, and then the it's just it can be very rough. So tell me a little bit about what you guys are doing in that respect.
Yes, so probably 3 decades already ago, the key was standardizing protocols, and it was very disjointed in other surgical settings because different surgeons had different ways of doing it. The advantage we had as anesthesiologists is we covered all the obstetric patients delivering, so we could give our standardized order sets to everyone. And initially we had it for 48 hours, and now we have it for their entire stay. So a lot of their recovery and analgesic management is managed by anesthesia. Not a big problem in America is that we give over a lot of the post-operative management, specifically analgesic management, to surgical teams. Mm-hmm. So it's a little different in the obstetric domain.
Can I clarify, Brendan? Is it we have nurse-led, midwife-led obstetric services in the UK. Now there are doctors leading the more complex issues, but the vast majority of births are from flash to bang is mum, midwife, and sometimes some other people hanging around to do some hand-holding. But the docs very rarely get involved. Is it quite different here? It's
very different. Obviously, different parts of America and different states and different hospitals have different management. We have very few midwives at Stanford. We're slowly increasing, but they tend to be centered around labor management.
Yes.
The postpartum setting, it's all nurses who do a fantastic job within a care model, but it is a physician-led care model.
So when you are trying to integrate some of the principles of enhanced recovery, are there things that certain are in OB that you can focus on specifically for that service line, or what are you looking at as far as the big picture?
Well, as we were chatting, I was suddenly realizing there's no other surgical model that requires a patient to be providing for someone else while recovering from surgery. When Monty had his knee replaced, or if he hasn't had it replaced, he should.
The only bit that works still.
But you're lying in hospital and your family's probably feeding you and looking after you, whereas as a new mom,
you're doing all that for someone else. Yeah.
You asked me what we do already or what we should do differently. It is it's surgery, it's abdominal surgery. It's associated with moderate to severe pain if left untreated. So multimodal analgesia is how we approach it. In the United States, intrathecal morphine is viewed as the gold standard, and because all these cases are done with spinal anesthesia, we can give a small dose of intrathecal morphine. and then we do around-the-clock non-steroidals and acetaminophen without them requesting it. And then for breakthrough pain, we don't rely on intravenous medications at all. Very few women use it. They get offered oral, in our setting, oral oxycodone. We recently changed to a new order set, which shows you just the difference you can make with wording and orders. They used to get 5 if their pain was up to 4 out of 10, and 10 milligrams if it was greater than. We halved those tablets. We got pharmacy to break them in half. And they were allowed this second half an hour later if their pain wasn't managed. And just that led to a 56% reduction in opioid use. So we use very little opioids now afterwards because of the multimodal analgesia. And then we have a few techniques to further reduce it. We do wound infiltration in select patients with continuous administration with a catheter. And as rescue techniques, we offer tap blocks, so transverse abdominis plane blocks, or gabapentin. We don't routinely use it, just in patients who are not managing well with routine care.
Are there any concerns being expressed about the potential addictive components of oxycodone in particular? Because there's a lot being talked about it in recent years. Yes,
it's extremely topical in the United States. It's estimated that 1 in 300 opioid-naive women become chronic opioid users afterwards. So there's been a huge focus on reducing opioid requirements. And we've led the way, if you look at sequence of studies that we've conducted and changes in order sets, like I mentioned, reducing it significantly more. So a third of our patients, 35% of patients, will not take any opioids. Wow. And then in the ones that do, we try to reduce as much as possible. And the latest, I was chatting a little bit about how we keep adding stuff, is stratifying discharge opioids based on the patient's needs. And there's more work being done. That what happens in the United States is often the order set is done prior to them even coming for their surgery, whereas now they're trying to give appropriate amounts. So we're going to stratify what women get before they leave based on what they've needed in hospital.
But you're sticking with the oxycodone. You haven't shied. And why? Because we're telling by some people, we have some very emotive interviews with some of our colleagues here who've personally been addicted, and they have pointed the finger at the addictive potential of oxycodone. Is that not what you think? The upside is worth the...
I think you have to offer, the vast majority of women need some breakthrough medication. So the question is what to choose. So codeine and tramadol are now no-nos for various reasons. The FDA kind of got hold of that and said there's concern about them, partly because of the metabolism, the cytochrome metabolism variability. It leaves the hydrocodone and oxycodone. There's been recommendations maybe to moving towards hydromorphone, but again, you're still going to run into the same addiction potential with that, maybe even higher. So there's no good opioid that's less likely to cause that. So the emphasis has to be on trying to reduce the number of women who need it and those who need it to use as little as possible, and for then you to be alerted to the women who are using more than they should, to rather than keep escalating the opioid dose, go and then do rescue, add in gabapentin, do a rescue tap block, etc.
Are you doing, remind me again, you are doing scheduled NSAID and acetaminophen?
Yes, and it's very important to have it scheduled without women asking, because it drops off the requirements for opioid. And in fact, we used to have oxycodone and acetaminophen combined, the combination tablets. When we uncoupled it, we reduced the opioid consumption by 50% in the first 24 hours and about 35-40% in the next 24 hours.
Were people holding the Tylenol and giving them?
Well, every time they requested breakthrough medication, they would automatically be getting an opioid, when we could reduce those requests for breakthrough by giving acetaminophen. And the reason why the combination is so well liked is because it works nicely together. But if you're taking regular acetaminophen, your concentration of acetaminophen is already there for the opioid to work synergistically or additively with.
How many do you let them go home with? Because I've also heard some horror stories. Didn't you tell us that you went home with a sack full?
Oh, yeah. It was like 60, pills. It was ridiculous. And that's what I was just going to ask, is one of the hardest situations to deal with is talking to your surgeons, because obviously if anesthesia is writing orders when they're in the hospital, the surgeon is going to be dictating how much narcotic is going to go home with that patient. So how did you handle that conversation? Was that a big point of contention? How did you overcome it?
So if you actually look at what the average discharge number of opioid tablets, and a big multi-center study looked at, of which Stanford contributed, it's on average 40 tablets. Mm-hmm. There's other studies showing massive variability, up to the 60, 100 tablet range. Yeah. The more tablets you let women go home with, the more they use. There's actually in several studies showing a beautiful correlation with give more, use more. And generally, half of the tablets you give are left over on average, so a lot of waste. There's also concern of what happens to these tablets. They're not adequately disposed of afterwards. So by giving less, you can use less. The problem is you've got to be careful with the other side, which is the refills. And if obstetricians are getting too many calls at 3 a.m. to say, I've run out of medication, that's a problem. So you walk in the balance between giving enough but not giving too much. There's Vanderbilt did an interesting study looking at an algorithm based on usage and then prescribing based on the number of tablets used between 24 and 48 hours. So that's one example of what you can do. What we are moving towards, we're just transitioning to this, is having a stratified approach. So women who are not needing opioids have a small rescue pack, because you're now going home, you may exert yourself, walk up, just something that you may need, just a few tablets. Then we will move towards a middle range, which is sort of in the 15 range, and then the more traditional 30 for the high-end users, the 20 to 30, with them not being allowed a refill without getting back to us and us looking more into their multimodal.
Yeah, I would imagine if they're still having pain, then there's probably something going on.
And the key thing is good instructions.
Yeah.
That you've tried your acetaminophen and your NSAID before going to opioids, because a lot of women don't get those instructions, and they take it as their first line. The other problem is they think they have to take the tablets and complete it like a course of antibiotics.
Yes.
So, well, and that's what I was going to... Two things. One is it's the instructions for going home and continuing. Do you continue the acetaminophen and NSAID? Yeah. So some people probably, when they get home, are not always completely complying on that. And
correct.
Have
and our new order set comes with very clear instructions about only if you haven't managed to control your pain with that. This is a new field, and finally... anesthesiologists and teams are getting together to address this, because before it was just prescribe standard amount for everyone. So as an example, we're talking about my wife, who needed either one tablet on her first section and 0 on her second one. She got her standard 30 or 40 at the end when she left hospital, which we filled the first time around, but the second time always still had the previous.
I went into I think after I had my second, I went into my medicine cabinet. I was like, oh, I still have the leftover from the first. Need to get rid of those.
Of course, for those of you listening who are interested, of course, these clinicians here had them disposed of properly.
Of course, that's what I was just going to say. I took them to the drugstore and had them disposed of.
Or ground them up and put them with coffee and buried them in the garden, or whatever you're supposed to do.
No, that'll get into the water table. No. So, Monty, did you have another question?
I just realised I bombed the opening section by suggesting that ERAS had nothing to offer for C-section, but obviously it does. So we should probably go back to that.
No, well, and that's what I was just going to start. And what are some other opportunities to utilize enhanced recovery for the OB elective section patient, or actually emergent patient as well? Are there opportunities there?
It is difficult because you do have two populations, the scheduled sections versus the emergency ones. They've proposed a more inclusive one for elective cases where you can start off with education and various other aspects, but a more focused one for those unexpected cesareans where you really have to focus more on peri and post-operatively. Yeah. I think it can offer a lot to women. If not getting them home sooner, at least being ready to be home sooner and enhancing their recovery, because as we mentioned, they're trying to look after another baby and an annoyed husband. Or, I don't know.
No, not at all. What are some other elements that are appropriate for this patient population?
So it starts preoperatively with good patient education, setting expectations for what's to come, both with pain relief and breastfeeding in particular. Ideally starting some form of breastfeeding education very early on. Limiting the fasting time.
That's what I was going to ask about, yeah.
And ideally taking a carbohydrate drink up to 2 hours prior. Although we've changed our instructions on that, we found that a lot of women don't like the carbohydrate, or at least they stick to water because you're already bloated and nauseous and got heartburn, etc. So it may not. That's something that you may not extrapolate from other surgical models. So limiting how long they fast, and then intraoperatively emphasis on limiting fluid, perioperative warming, which generally is most effective if you start it in the holding area prior to surgery, because you get vasodilation and it's very difficult to prevent it even with intraoperative warming techniques. Management of blood pressure, because you're going to always get drop in blood pressure, and realizing it's an afterload issue, not a preload issue, so emphasis on vasoactive drugs like phenylephrine. And then getting your multimodal analgesia going very soon on, and giving anti-nausea and vomiting medication. So at our institution, everyone gets 2 antiemetics, and they already have 2. So an IV acetaminophen and IV NSAID, so ketorolac, already before they get to the recovery.
We were touching earlier about the fact that it's been common in obstetric practice to allow women to mobilise immediately post-operatively, but part of enhanced recovery elsewhere is to set movement targets, i.e. day 1 is this amount of walking, day 2 is that amount of walking. Do you have that going on as well? Do you have distances marked out and goals? So
as I was chatting to you earlier about, we're sort of still transitioning from ERAS light to ERAS heavy, and there are certain things that we haven't fully instituted, and that's an example of one which will be in the coming months instituted. The difficulty you have with women after Caesarian delivery is they have spinal anesthesia on board. You have to wait for that to regress. You do have some blood that's coming out of the vagina as the uterus involute. So, mobilizing and the assessment of that can be complicated with mobilizing. Saying all of that, it's just excuses. You really just need an institutional practice that has formal mobilization practices. And the key is getting that urine catheter out soon. Everyone gets intrathecal morphine, so in addition to the spinal, it can affect bladder function, but it's no reason for the old practice, which is keeping it in until the next day. There's no evidence.
I know, it's like, get that thing out. You can if you have issues later on, you can, but get them moving, get them up and going as best you can. Any other aspects that are traditional kind of enhanced recovery principles that you would use post-operatively?
Well, as already been discussed, mobilizing is probably the key. Getting patients to eat and drink as soon afterwards as possible, which patients
it's not usually hard because they're so starving.
Yes, there's no problem in our population. Although we've now introducing, as was mentioned, clear metrics. If a certain amount of time has gone past where you're not eating, then to investigate it. I think before we left a little bit too much to the patient and the nurses, so now there's clearer metrics and there's patient-facing documents that they realize that they have certain goals to attain, so they can take some ownership for their own recovery.
So part of... Oh, I'm sorry, Monty, were you going to ask?
No, I was going to finish on this bit.
No, so part of enhanced recovery that we've been talking a lot about is that every service line, every surgery, it can look a little bit different. The pathway can look a little different and have different elements. And one of those is patient education, patient engagement, patient support. So, we keep talking about the fact in the U.S. that there's not a whole lot of support for mothers. So do you think something like adding, a better support system, not necessarily just in the hospital, but sending, someone at home? I mean, Monty talks about the midwives that come and do the checks on the baby. Like, can that be part of an enhanced recovery program?
For many reasons, the Caesarian delivery surgical model is a lot more complicated than the average surgical recovery because of you have another being to look after. You've got to check their health. You've got to get breastfeeding
which is always a challenge.
And it can be a big challenge. So to do that all within a hospital setting takes time, even if you try and manage things rather than sequentially, and have a coordinated approach. But it requires everyone to be involved. You need to get your neonatologists involved, your obstetricians, your lactation consultants, nurses. So it's a lot more moving parts than the average surgical recovery.
Yeah.
Can I just briefly touch on the Centres of Excellence that I've heard about?
Yes. So this year's SOAP, so Society of Obstetric Anesthesia and Perinatalology, launched the Centres of Excellence. So the idea behind the Centres of Excellence is to try and improve maternal care. And States has been talking about trying to introduce metrics by which you can judge hospitals of the care that they do. It's just difficult to come up with meaningful metrics and to measure them adequately. So we decided to have a totally different approach, which is come up with a set of criteria we believe would constitute excellence in care. And centres that offer that, we wanted to recognise them. We wanted to allow them to leverage the list to their own hospital to say we need the resource of the staffing to meet this expectation, and then enhance the subspecialty of obstetric anaesthesia, to allow it to be viewed a little differently. There's a lot of emphasis on trying to reduce maternal mortality in the United States. You've probably seen a lot of the press coverage on this, and this is a step towards that. At least focusing on obstetric anesthesia, which often gets buried amongst the details. ACOG came up with the levels of care that you expect each centre to provide based on number of deliveries and the complexities of delivery. There's only one line for anesthesia, and it was very limited. So we felt like we wanted to give more of a global view of what we would expect.
So, if I'm right, I mean, one of the rumours, I haven't checked the figures, but the maternal mortality rates and the live births per 100,000 are not what you would expect proportional to your spend on healthcare. Is that right?
Yes. It's higher by far than any other developed country, which is ridiculous. Now the question is it...
Yeah, how does that work?
Yes. So, you always worry about how accurate the data is in other countries relative to states. Definitions and various other things that can affect the statistics. United States is a very big country and has huge heterogeneity in the care it provides, so that variability is inherent, and you even see it in different states. If you compare, let's say, California to Texas, but it's way higher than it should be. It's way higher than the WHO suggests a level should be, and it's about time that we did something about it. And California has tried. There's a lot of press about initiatives that have been done towards that, and we're trying as our Anesthesia Society to try and work from our end and our area of responsibility.
And the higher is the maternal mortality is much higher, but the live births per 100,000 is also disturbingly the wrong way as well, isn't it?
For neonatal?
Yeah.
It's higher than it should be. Relative to all I'm not as familiar with the relative statistics. Clearly it's much better than developing world countries. You have to also appreciate we have a high-risk population in the United States. There's a lot of women who probably shouldn't be having babies that choose to go on to have. In the 17 years I've been at Stanford, the demographics has just changed immeasurably. So I think even if we're doing a better job, we just have sicker patients who just do worse consequentially. So it's changed. The UK is going there as well.
It has, but are we going the wrong way? I think we're going at the moment, and I think that our longevity is taken a turn for the first time as well.
Yeah. So one more question, because our theme is enhanced recovery. What is SOAP doing to institute or make that a part of what they are requiring for a Center of Excellence? Is that something that is standard?
So outside of the Centers of Excellence, they are currently developing consensus statement for enhanced recovery, and they'll come up with a SOAP proposed enhanced recovery for Caesarian delivery. Within the Centers of Excellence, we cover Caesarian delivery management and touch on all the key aspects. We were hesitant to go to making it an absolute criteria because a lot of places haven't moved fully over, and as we were discussing before the podcast, struggle with the definition of, what do you need? What are the minimum requirements to call yourself enhanced? And I think a lot of people are doing it without knowing they're doing it, and some people think they're doing it but aren't.
Yeah. All right. Yep. So this will wrap up our session with Dr. Carvalho. Thank you so much for talking with us today. It's been enlightening, and I always love talking about something I can relate to for sure, and many of us. So again, thank you. Thank you so much for joining us here at Top Med Talk at Anesthesiology 2018. Please be sure to subscribe and enter for a chance. If you subscribe, you'll be entered in for a chance to win our beautiful Marshall speaker. That's it right there. Isn't that nice?
You want that, Brenda, don't you?
I'm just going to nick it.
No, not before you sign up.
You
before
can
you
take
subscribe.
the boy out of South Africa, but you can't take South Africa out of the boy.
Be sure to subscribe, and please be sure to interact with us on Slido.com #TMTASA18. We'd love to hear your questions. We're going to be talking a lot more about obstetrics. Enhanced recovery for obstetrics tonight at the live symposium.
Absolutely. We'll be live streaming that.
We'll be live streaming that with Smith's Medical from the W. We're talking to Elizabeth Chareau, who's an obstetrician from the East Coast, as well as Vincent Chan, anesthesiologist, and we'll be talking a little bit about pain there. So please enter your questions. We're going to be interviewing Bobby Jean Schweitzer here in just a bit and finishing up our day here in the Connection Center with her. So we'll be back in just a moment.
Top Med Talk.